talk before we head off back upstairs. So atherectomy, really a device overview. It talks about my recipe for success. I really don't have one. I don't think anybody does. It's really kind of what you see and how you choose. These are all my disclosures. As George just showed, Fabrizio's paper is fairly become seminal in what it describes as being an impediment to doing many therapies, whether it be stenting or drug therapy. And the longer the lesion, of obviously patencies decline. But really, calcium has become a barrier for anything we do, whether it be expansion with balloon, expansion with stent, or delivery of drug. So from an atherectomy standpoint, there's a series of a myriad of devices which you can use, which are either rotational, orbital, excisional, or atheroablative. And they all have certain positives and negatives to their bailiwicks of what they can do, what's in their wheelhouse. I'd like to show you the first one, which is the Jetstream device pathway. And it is a stainless steel flute up front with a aileron in the back. When the device spins one direction, the ailerons are held tight, and when they spin the other way, they flip out, and they start to chip more. So these are really, the front ends are grinders, and then the back ends, the size adaptable design at the speeds that this thing rotates, chip more often. And they have, about 1 millimeter in diameter differences for both the popliteal and SFA devices. And then they have smaller devices for the tibials. They do two things that are important. One is they flush to clear up this debris cloud, and then on the back end there is an aspiration port. You have to understand that the aspiration is about 80 to 85% of what you infuse, so there is always going to be some relative remainder of stuff that should be out there, which can go downstream. There is the Jet registry. Lesion length is about 16 centimeters. This was initiated before Pathway was taken over by Boston Scientific, and when they acquired them, they then shut down, discontinued the registry. However, we do have the data set on around 258 lesions at a 16 centimeter metric. In the Jet registry as published, we also separated out those that got no stent versus those with stent, and it becomes important to understand some of the distinct differences between these patient populations. Overall, about 14 centimeters for the non-stented group and about 20 centimeters for the stented group, with most everybody excuse me, being mostly Rutherford-Becker 2 and 3. What was most interesting is that although the procedure time was as shown here and the total Jetstream time was actually fairly acceptable, we had about a 38%, 35% crossover rate from the folks who went in with Jetstream PTA. Remember, this is PTA alone, not DCB at the time of this trial. We had a 93 or 98% procedural success, but a fair number, over a third of the patients crossed over to receive a stent. Now, if you look at this, if you look overall, the post-Jetstream was about 44%. In the non-stent group, just under that, about 38%. But in the longer stent group, remember, in the stent group, which was 20 centimeters, a longer lesion, was 54%. This is, again, core lab adjudicated. And then the post-adjunctive therapy, plain old balloon for the most part, was 9.8%. With balloon alone, the non-stent group was about 12%. And then with the stents, we got about 6.6%. What was most interesting is if you looked at the outcome, if your oculostenotic reflex is intact, in other words, you can tell if you got a tight lesion or not, you do pretty well on the outcomes on the other end of both primary patency as well as TLR. So when you look, if it looks bad, and doesn't look like it's open very nicely, then go ahead and put an endoprosthetic in. And you can see how these overlap on both TVR and TLR through the time frame. And this is one of my cases. We did this at a time where we could not deliver, one of the few times we could not deliver with distal protection, and blades down, blades up, made 2 passes, and had a nice pleasing angiographic result with no endovascular prosthetic placed. The Liberty trials in orbital system, you've seen the data set. I just want to draw your attention that it was the target lesion was considered calcified in over 60% of patients, both above knee and below knee. Their target was across the myriad of all Rutherford-Beckers all the way to Rutherford 6, and their primary therapy was almost exclusively PTA. There was a very small smattering of DCB, and almost exclusively most people used orbital atherectomy. Liberty did many things good. One thing that it does present is the claudican group primary patency, 83% at the end of 12 months. They did not show a primary patency for the tibials, which is unfortunate. It's just a male endpoint. But orbital atherectomy does very nicely. This is a case from Tony Das. He let me use with occlusive disease following the crown use and adjunctive angioplasty. You get a nice pleasing angiographic result. So I haven't spent a lot of time for the whole series of different things for calcific algorithms, but what's out there and what to choose. There are several devices now available for debulking. Calcium is principally a difficult impediment. The critical question remains, is debulking part of vessel prep for all or some of the cases, for all of the time or some of the time? Each device has some compelling data. Some are better for calcific lesions, some are better for softer lesions and lesion makeup, but some are better for their ease of use. But there is no question that we need better data as to whether atherectomy is necessary at all in our vessel preparation, but it appears very useful in these calcified lesions. Thank you for your attention.